Please be seated. We'll go back on the record in the matter of State of Utah versus Martin MacNeill. Mr. MacNeill is present with his counsel. The state's attorneys are also present. The witness is on the stand. You may proceed.
Thank you, Your Honor. Okay, Dr. Dawson, we've talked about a number of factors that affect an analysis that you perform on a toxicological report like this. And I wanted to ask, this method you described of taking a blood sample and the reported amount or level or concentration of a drug in that blood sample after a person is deceased, working in all of these factors and arriving at a conclusion, how is that regarded by other pharmacologists or toxicologists?
I think that's a generally accepted procedure.
How widely is that process used?
Everyone I work with does the same thing.
Okay. One more question about metabolization of a drug. Blood circulating through the body, is that part of that process that will metabolize a drug?
Yes.
I'd like to take you now to Michelle's case, and specifically the toxicology report in Exhibit 33, I believe, that that I provided you. May I approach, Your Honor?
You may.
Well, I'm going to give you what's been marked as Exhibit number 1. And this is the case file from Dr. Thompson, who is the cosmetic surgeon who performed the surgery about a week or so before her death. Are you acquainted with Michelle MacNeill's case?
This information I've seen before, yes.
Okay. Have you worked on this case?
Yes.
Have you given investigators an opinion about the toxicology report?
Yes.
What materials did you receive to prepare that opinion?
I'm a little bit fuzzy on the timelines because when things appeared, but there. Obviously, there were some medical records. There was this record. This record came a little bit later, but some of the initial investigative reports that were done. There was the emergency room records, and more recently, the reports done by other outside advisors or consultants in terms of some of the medical issues.
When did you receive the autopsy report from the medical examiner?
Yes.
Okay. I'm going to direct you to Exhibit number 33 there, the toxicology report. Did you form any opinions after analyzing that report specifically?
Yes.
Will you, I'm sorry? Okay. Grab 1 minute.
You may.
I'm sorry, let me clarify something. To what person does that report pertain? Whose blood sample is that?
This was a toxicology report associated with the Michelle MacNeill.
Okay. What drugs are listed there as having been found in her blood after she died?
Diazepam, nordiazepam, oxycodone, promethazine, and zolpidem.
I'd like you to, if you can, for your convenience, I've tabbed a certain page in Exhibit number 1, Dr. Thompson's file. On that page and the subsequent page, will you describe the contents of those pages?
These are photocopies of the actual prescriptions, I believe, that Dr. Thompson wrote at the time following her surgery.
Okay, thank you. Back to the toxicology report, you mentioned one of the drugs is diazepam.
Yes.
Which of those prescriptions would the diazepam represent?
Valium, 5 milligrams.
Okay. Now, what type of drug is Valium or diazepam?
Diazepam is a generally classified in one category as a CNS depressant, but it's used as a anti-anxiety agent. It's also used as an anticonvulsant. It's used as a smooth muscle relaxant, sometimes as probably more inappropriately as a sleep aid, but it has multiple purposes, but primarily it was used as an anti-anxiety agent.
Okay. How does it create its intended effect?
This medication acts on certain receptors in the central nervous system. It's sort of like if amphetamine is the throttle, benzodiazepines like Valium are the brakes to the brain, and it slows things down.
Okay. What was the level reported in Michelle's blood?
The reported concentration of the diazepam was 0.1 milligrams per liter.
How does that relate to a therapeutic dose? Or
Well, I need to stop for just a moment, and when we talk about a therapeutic dose, the therapeutic dose is what works for a patient. 1 milligram might be enough. It might take 10 milligrams for a different patient. And so when we talk about that, clearly a 5 milligram dose would produce an effect on anxiety in just about everybody, short of somebody who is 300 pounds.
okay, okay. I'll come back to that. When it comes to you mentioned nordiazepam as being on the toxicology report. Does that match up with any of the prescriptions that Dr. Thompson issued?
No, no, it doesn't.
What is nordiazepam?
Nordiazepam is the active metabolite of diazepam.
Will you define what you mean by active metabolite?
It possesses pharmacological activity similar to that of the parent compound diazepam.
What produces nordiazepam?
The actions of the drug metabolizing enzymes in the liver on diazepam to remove a methyl group and convert it into nordiazepam.
Okay, so if I take Valium, I've taken diazepam, that's going to be through my system, and as my liver breaks it down and metabolizes it, it produces nordiazepam. Is that a
Yes.
fair summary? Okay. What was the level of nordiazepam in Michelle's blood?
The report here indicates it's less than 0.05 milligrams per liter.
Even as a metabolite, you said it was an active metabolite. Would nordiazepam still be having a similar depressant effect on the central nervous system like its parent drug diazepam?
Yes.
Next on the list, I think you mentioned, was oxycodone on the toxicology report.
Yes.
Which prescription would this one be?
This would correspond to the prescription for, I believe it was Percocet.
Okay.
Yes.
And what type of drug is oxycodone or Percocet?
Oxycodone is, in the broad, well, let me stop for a second. Percocet is a combination of oxycodone and acetaminophen, or this active ingredient we find in Tylenol. The combination of these two has been, because their analgesic effects are synergistic. So the oxycodone is generally described as another CNS depressant, but it is, in more accurate parlance, is considered to be an analgesic of the narcotic category. It's a controlled substance that's very potent.
Can you tell us what analgesic means?
Well, for pain,
Okay.
pain control.
And what is its effect on the central nervous system?
Again, it would be cause sedation, cognitive impairment, slow movement.
Okay. You referred to, when you were talking about diazepam, is slowing things down, putting the brakes on. Is that accurate?
Yes.
I'm sorry, is that accurate for oxycodone as well?
Yes.
promethazine. Which prescription would this be?
Promethazine,
I'm sorry, before we move on,
Oh.
will you tell us what the level was reported in the toxicology report for oxycodone?
for oxycodone, it was 0.04 milligrams per liter.
Okay. Are there other forms of oxycodone, other trade names for oxycodone, maybe without the acetaminophen?
Without acetaminophen? Yeah, OxyContin.
If I took Percocet, I'd have oxycodone in my system, is that correct?
Yes,
If I took OxyContin, I'd also have oxycodone in my system?
yes.
Okay, let's move on to promethazine now. Which prescription would that one be?
That would be the prescription for Phenergan.
What type of drug is Phenergan?
Well, Phenergan is an interesting drug because it's used for several different purposes. It was originally in a group of compounds that were being screened to be used as antipsychotics, and it turned out that it was probably a better antihistamine, anti-nauseant than anything else, and so it got kind of shuffled off into that category and that use. But it too has CNS depressant qualities.
That brings up an issue we haven't discussed. I'd like to maybe visit with you briefly. When it comes to, you're talking about promethazine, originally it was intended as an antipsychotic, is that?
Well, it's closely related to antipsychotics. There's a whole series of compounds. Thorazine is one, Maloril is another one. These compounds there was a huge explosion about 30 or so years ago in terms of new drugs trying to treat mental illness. And there was a whole series of compounds that were developed, and this was one of the analogs that was looked at that never really was fully developed because of side effects, one of which was the CNS depressant effects.
I see. And so now, but it has been shown to be effective for anti-nausea.
It apparently has some effect in the chemoreceptor trigger zone in the brain, which is part of where nausea occurs. And it also has some anticholinergic properties that are useful, but it is used almost exclusively now for its anti-nauseant effect.
When a drug targets certain receptors on the brain, let's say we're taking oxycodone for pain, and it works on receptors in the brain to dull the sensation of pain, is that fair to say?
That's close. If I can expand on that just a little bit. The best example is to think about it in these terms, that there are some effects on the receptor pathways that, depending on the drug, there's different receptors that are involved in analgesics, but generally what happens is drugs like morphine, as an example, has more of an effect on the somatic sense about pain. In other words, you might still feel the pain, but you don't care. With oxycodone, it's more potent, and it tends to block some of the pathways, but it also has that same effect. The pain doesn't totally go away, but your somatic perception, if pain is worse at night, for instance, because you're not thinking of anything else than it is during the day. And so it's that somatic piece of pain that's part of that cycle. So it helps interrupt that cycle where that somatic perception or input into how we perceive pain.
And perhaps my questions are not quite as articulate as they need to be. What I'm getting at is the overlapping effects of these drugs. If I'm taking oxycodone for pain, does it affect only my pain, or will it affect other functions of my system?
It'll affect other functions as well.
How about Phenergan, for example?
Yes.
What are some of the other functions that, in addition to treating my anti-nausea, what else will it do?
Well, typically it will also, its anticholinergic side effects will also cause potential for urinary retention, for drying up mucus secretions. It's very effective at treating, in some cases, people with allergies. because of the antihistaminic effect, but it's also the sedating effect. It limits its use there, but it also affects the CNS alertness.
Is it fair to say that each of these drugs that we're talking about has a specific symptom that it's targeted, but also has other effects on the system as well?
Yes.
Okay. What was the, I think you've mentioned this already, but just to make sure, what's the effect on the central nervous system of promethazine?
Promethazine generally would be considered to be a CNS depressant, but its specific action is as an anti-nauseant and anticholinergic.
Okay. What was the level reported in the toxicology report?
It looks like if I interpret this correctly, it's approximately 0.1 milligram per liter.
Okay. Lastly, I believe is zolpidem on the toxicology report.
Yes.
Is what prescription does that correspond to?
That would be the Ambien.
Okay. What type of drug is Ambien?
Ambien is, in the broad categories, a CNS depressant, but specifically it's used as a sedative hypnotic to help people sleep.
Okay. And what's its effect on the central nervous system?
Well, it's the brakes again, but it's much more potent brake than, say, Valium in the sense of causing sedation. It works on a little bit different set of receptors, similar, but slightly different than, say, Valium does, and it is much more potent binder to those receptors and inducing sleep.
Okay, so Valium is meant to help reduce anxiety but still be able to be awake and function.
Relatively speaking, yes.
Despite the CNS depressant effect.
Yes.
Ambien's purpose, however, is just put you under, right?
Yes.
What does the depression of the central nervous system look like, generally?
Well, it's a continuum that starts generally with a diminished alertness, some cognitive impairment, some cloudy functioning, maybe not. It's sort of like the early stages of, at the very earliest piece, it's sort of like the earliest stages of a head cold when you're not focusing, you're not thinking properly, you're not able to conduct certain sorts of mental functions as clearly and quickly as you normally would be able to. As you begin to cloud that sensorium and you begin to further influence the level of CNS of function, you start to have not only difficulties with, say, for instance, recall or, for instance, multitasking. You can't do two things at one time as well as you normally would. You're not able to do speaking as clearly as that begins to progress further. You begin to have slurred speech. You have problems with gait or ataxia. You can't walk a straight line. You can't. You might have to hold on to something to hold yourself up. And it just continues to the point where it gets to where it's very difficult to maintain arousal or alertness, and it just continues on deeper. It's like walking into deeper and deeper water until you get to the point where they either fall asleep and are arousable, or you could become comatose if it gets severe enough. Valium is one of those that, in effect, when you go to sleep, you've put the brakes on the brain, and you're asleep. You're not alert to anything in your surroundings. That's the purpose.
Okay. As opposed to sleep, though, if let's say if I had these drugs in the average adult system, let's say I'm tired, I'm working, I'm falling asleep, but I want to stay awake. I can force myself to stay awake. Would someone be able to force themselves to stay awake if they had all these drugs on board?
Sustained.
Did you employ this method that you've described earlier for analyzing a toxicology report? Did you employ the same method when you were asked to analyze Michelle MacNeill's report?
Yes.
Will you, okay, I'd like to ask you about how these various drugs work on the central nervous system. I think you've explained already, but if we could go specifically by drug, how does diazepam create that central nervous system depression?
Well, by its action on the what we call the benzodiazepine receptors in the central nervous system, which are GABA receptors, and it modulates downward the electrical activity in the brain. In other words, it depresses the electrical activity.
Okay. How about the nordiazepam? Does that
Same thing.
How about oxycodone?
Oxycodone works at different receptors than the benzodiazepine, but it also causes a CNS depressant effect that's working through a different mechanism. It's working through a different set of receptors, and so this is what makes the effect additive. In other words, both drugs are working at different sites, and so when there's a combination of the two drugs, and this is a very basic concept, that if you have this drug producing this amount of effect alone and this drug producing this amount of effect alone, when you put them together, you have an additive effect that's greater than either one alone.
Okay. So one drug is putting me to sleep in this area, another drug is putting me to sleep in another area, and their combined effect is greater than just each one.
Yes.
How about promethazine?
Promethazine works through histamine receptors in the brain, and that's the basis of its sedative effect, or at least a significant amount of it. And it's similar in that regard to a drug like Benadryl that's in Tylenol PM and some of those other preparations as part of putting you to sleep. The antihistamines, the H1 receptor blocker antihistamines, what we call the first generation. I just went out in the weeds there on you, and I'll get back very quickly. But that group of drugs has a profound CNS depressant effect, and they work on a third set of receptors different from the other two, and so you end up with a third factor in there that the combination of any one of those alone will produce a certain amount of CNS depression depending upon dose, but you start putting them together and their effects are still additive.
Okay. And then finally, zolpidem.
Zolpidem acts on there's a family of receptors that they're called the GABA receptors in the brain, and they're called, zolpidem is what we call a benzodiazepine receptor agonist, and that benzodiazepine receptor is part of those GABA receptor families. They're all kind of the same family, and I'm oversimplifying, so please bear with me. But as that is a fourth set, actually the 3.5 set, if you will, because the benzodiazepine receptors for the diazepam and for the zolpidem kind of fall in the same family, but the zolpidem is very specific for a subset of those receptors, which makes it different because that's where sleep occurs. And so you're actually taking a drug that is specific to put you to sleep. That's why you take it.
If we could go back, I'd like to talk to you about some of the factors in your analysis of Michelle's toxicology report. Did you have information about Michelle's body type?
Yes.
What information did you have?
General description of a middle-aged female of approximately 170 pounds with no obvious signs or symptoms that would be consistent with any metabolic medical issue.
So would she be described as your average patient in that sense?
Average female patient, yes.
How is foundation lacking?
I believe that the average patient that he described previously was a 5'10" male. There's no foundation to show that a 50-year-old female, 182 pounds, is average.
May I respond, Your Honor?
Yes.
I believe you used the 5'10" male as an example of the 66.66 or nearly 70% of that bell curve that not just males, but the average population fits into, and that applies to women as well.
I'll sustain the objection on foundation. I think he articulated other factors he looks at as well. You may lay further foundation.
Let me ask you specifically about that average patient. Does that include men and women?
The men and women are their own, kind of their own category, but in the sense of there are some exceptions for women that are not exceptions for men. And for a female of this description, in the absence of other confounding factors, would not otherwise appear abnormal or out of the normal range.
Okay. Well, let me clarify my question. Then I asked you whether she would fit into that average patient category. And if I understand your answer, you're saying she would not because she's a female.
Well, in the sense that she would not be out of the normal range at least at this point for a female. If I'm not sure I understand if you're talking about everybody put into one category in one group, then in some respects you need to consider females separate from males.
Okay. No obvious indications of something that would affect her metabolism of drugs?
Not on the surface, no.
What was your opinion about Michelle MacNeill when it came to her experience as drug naive or drug experienced? Excuse me, her status as drug naive or drug experienced?
I did not see anything that would suggest that she was, other than some estrogens and some other medications, there's nothing there to suggest that she was on a long-term CNS depressant use.
Okay. Did you have information about the prescriptions and things that she'd been given from the cosmetic surgery?
Yes.
May I approach, Your Honor?
May.
I'm showing you, or I'm going to show you. This is Defense Exhibit D. That is a controlled substance report, basically a controlled substance history for Michelle MacNeill. Does that seem accurate to you?
I'm sorry?
Does that seem accurate? This Doppel report for Michelle MacNeill?
Yes, this is from the Board of Pharmacy, I think.
It's from Utah's database about
Yeah,
prescription.
I'm familiar with these type of reports, yes.
Okay. I'd like to have you look at the two prescriptions at the top of that table in December of 2002. Do you see those?
Yes.
What are they prescriptions for?
One for hydrocodone, APAP, which is the generic for Lortab or Vicodin, as it might be the brand names, or the second one is for diazepam 5 milligrams. That was for number 20, and then for diazepam 5 milligrams, number 20.
On the hydrocodone, are you aware of whether that was prescribed to Michelle MacNeill?
That's the indication on the report, yes.
I'm sorry, let me clarify my question. Are you aware of whether that was prescribed to her by Dr. Thompson as part of her cosmetic surgery?
I don't see this would have predated that.
Right.
But
I'm just asking, not based off of this report, but based off the materials that were provided to you.
okay, yes, those at the time of the cosmetic surgery, both those drugs were prescribed.
Okay. Hydrocodone, is hydrocodone present in Exhibit 33, the toxicology report?
No.
Okay. Are there any other prescriptions from 2002 relevant to the drugs that Michelle was prescribed by Dr. Thompson?
There were other prescriptions for the same items, but nothing, no unique or new drugs.
Okay, those are later in 2002, is that correct?
Yeah.
Hydrocodone, diazepam also?
In December.
And what were the quantities of those?
10 for the diazepam and 5 for the hydrocodone.
Okay. Taking into January of 2003, do you see prescriptions for Lortab and Percocet?
Yes.
What were the quantities for those prescriptions?
The Lortab was 40, and the, let me get on the right line here.
Let me, instead of asking the quantities, let me ask you about how many days they were prescribed for. I think that might be clearer.
Oh, yeah, I was in the wrong column, sorry. Based upon the instructions for use, the lower tab number 40 should have lasted 20 days. And that's usually let me just explain that real quickly. When the prescription is written, take one or two tablets daily as needed for pain. The pharmacy does the input, and they'll put in an estimated day supply, and that's where that number comes from.
Okay. And then how about for the Percocet in January of 2000?
For the Percocet was for quantity 40 and estimated 5 days supply.
Okay. And then there's some unrelated prescriptions. If you could jump down to 2006, March of 2006.
Okay.
What's that, on March 21st? What was
There's another hydrocodone AP.
and how many days?
Quantity 12 for 3-day supply.
And then in August of 2006?
Ambien 10 milligrams, number 30, 30-day supply.
3-day supply. Okay, and then at the bottom we see the 5 prescriptions for April 2nd, 2007. That relates to Dr. Thompson's surgery.
Yes.
All right. Or would that be a reasonable conclusion?
Yes.
I'd like to ask you about using, let's go back to August of 2006, using Ambien for, let's say she used it for the full 30 days. Would that create a tolerance that would take her out of the drug naive category?
As of April, that would be still in play in April of 2007?
Let me just ask about August of 2006. If she took those every day for 30 days straight, would she have built up a tolerance?
There's a possibility, although it's unlikely.
And then the next question is, what about in April of 2007? If she took those 30 days and then stopped taking them without the next prescription or without any other prescription to follow it, would she still be tolerant in April?
No.
You talked earlier about patients that you've dealt with in the past who are drug tolerant, kind of walking them back to zero where they're on no drug. How would you describe her condition on Ambien in April relative to tolerant or having been walked back to zero?
There would be no appreciable tolerance at that point.
So is it possible to reset someone's drug naivete? So if I'm naive and I start taking Ambien and I build up a tolerance, is it possible to go back to being drug naive again?
Yes.
How is that done?
Well, in the sense of the tolerance with Ambien, there's probably less tolerance with that drug, particularly as we look at it in terms of its effect on sleep patterns. A lot of studies have been done looking at it for 6 months, even some up to a year. And when we were doing sleep research, we were looking specifically at what happens with time of sleep. There's two factors. One is how long does it take to get to sleep, and how long do you stay asleep? And the tolerance piece would be probably less about when you go to sleep, but how long do you stay asleep? And even after 6 months, there was very little tolerance associated with Ambien in the sense of losing effectiveness. There's some, but it wasn't statistically significant in most studies. So
are you saying even in a drug-experienced user, pertaining specifically for Ambien, the tolerance is not that great?
It's not as important as it is with, say, the narcotic analgesics.
Let's talk about the narcotic analgesics. You're referring to Percocet?
Yes.
On Exhibit D, when is the, before April 2nd, 2007, when was the last time that Michelle MacNeill was prescribed Percocet?
January of 2003.
Okay, and how many days?
5-day supply.
If you took that as indicated, would she have built up a tolerance?
It's possible, but that would resolve after discontinuation of the drug.
How long would it take to go back to no tolerance?
It's going to be somewhat variable, but a matter of days.
Okay. Fair to say from January 2003 to April of 2007, a little more than 4 years, we're would she have been reset by that point?
Yes,
Would she be drug naive when it came to Percocet?
yes.
How about diazepam? Before April 2nd, 2007, what was the most recent prescription for Michelle for diazepam?
December 2002.
And how many days?
10-day supply.
Now, there's one other prescription for diazepam before that. Can you read the date on that?
December 23rd.
So this is within about, what, 8 days of each other?
Pretty close.
Okay. How many on that date?
20.
For the diazepam?
Yes. For 5-day supply.
5-day supply. Okay, yeah. I'm sorry. I was mixing my numbers up. So roughly a 15-day supply in December of 2012. Is that fair to say?
Yes.
If she had taken those as indicated, would she have a tolerance for diazepam in April of 2007?
The only tolerance that I would imagine would be some diminishment of the cognitive impairment. There would be some adaptation to that.
Even what, 4-something years later?
No, I'm talking about just that period of time, within a few days after the time that December period was used. But after a few days, no, there's no residual tolerance.
Okay, so by April of 2007, would she be drug naive as it came to diazepam?
Yes.
The other prescription, I believe, is the hydrocodone. Or
Yes.
Lortab. Are those interchangeable?
I'll define interchangeable, because they're different strengths.
Okay.
Okay.
Okay. Let's talk about the most recent, before April of 2007, the last time she was described, either hydrocodone or Lortab.
That would have been in, looks like March of 2006.
Okay, a little over a year before.
Yes.
How many days?
Quantity of 12 for 3-day supply.
Okay, if she took those as indicated, would she have built up a tolerance to hydrocodone?
Unlikely, and it passed a few days, no.
Okay, so after the 3 days when she was taking them, she'd be reset and no longer tolerant?
Yes.
How about in April of 2007? Would she be drug naive when it came to hydrocodone?
Yes.
Thank you. Did you classify Michelle MacNeill as a drug naive patient in your analysis?
Yes.
What was that based on?
There was no suggestion that she was on an ongoing basis being treated with any of the drugs that she'd taken at the time of the surgery.
Okay, and you've said already, but that's taking into consideration the prescription she received for the cosmetic surgery roughly 8 days before?
Yes.
Did you have all the data you would like to have had about Michelle in order to draw conclusions based on that toxicology report?
No.
What would you say is some that was missing?
I would really have liked to have had a living blood sample that was drawn before the time that she expired. That would, I mean, it's in a perfect world, you'd want to know what her blood levels were at that time.
How would that help?
Well, that would eliminate postmortem redistribution as a discussion. There would also be important to know exactly when the last doses were taken and when they were taken and in what quantity. I never saw that information.
Was that information available in this case, as to your knowledge?
Not to my knowledge.
Were you able still to draw conclusions, even though you didn't have all of that information that you would have liked to?
Conclusions with caveats, yes.
Okay, when you mean with caveats, will you explain that?
Well, it's based upon those limitations. There are certain pieces of information that I didn't have that would have been nice to have. And at some point in time, if those pieces of information would be available, then we would revisit that determination.
The lack of that data, how did that affect your conclusions?
Well, in broad strokes, the conclusion stays the same. You can't put too fine a point on it. You can't say this was positively, absolutely where it was, where the blood levels were at that point in time. What we can say is that's what was in the blood at the time it was tested. So that's where we start.
So you're saying you're unable, because of those limitations in the data, you're unable to go back and say, it was exactly this level at the time of death, or it was taken at this time? Are you limited in those types of conclusions?
Yes.
What about the half-life? I don't want to be tedious, but I think we should talk about the half-life for each of these substances. Do you know what the half-life is for diazepam or Valium?
Diazepam has a wide range of half-life, excuse me, because of the way its physical chemical characteristics. It behaves a little differently. But you can expect anywhere from 20 to 35 hours, somewhere in that range of a half-life.
Okay, so, okay, thank you. How about oxycodone?
Oxycodone is in the 3 to 6 hour range generally.
Promethazine?
Promethazine is a little bit longer, but it's still in that less than probably 6 to 12 hours, somewhere along in there.
Okay, and how about zolpidem?
Zolpidem is very short. It's generally 2 to 3 hours.
All right. I'd like to ask you about the metabolite nordiazepam. What does its presence indicate to you?
Well, its presence is a function of the diazepam being present, and it's a metabolite. The body converts diazepam to nordiazepam, and there's a pharmacokinetic principle here that's very important, because that drug has a very long half-life. In some patients, over 100 hours, and so it can persist for a very long time. And the fact that what we typically see after doses of diazepam is we'll see the diazepam first, and its blood levels will be at some point, but it's quite a while after that we begin to see the nordiazepam appear. And without knowing exactly when the dose was taken, it's hard to speculate about what that relationship really means in terms of the quantity of the nordiazepam versus the quantity of the diazepam, except to say that if it could be very early after the diazepam was taken, or it could be that because it persists for such a long time that it just hung around a day or 2 or 3 days after the diazepam was taken. You have to be you have to understand that relationship between the very long half-life metabolite and the relatively kind of intermediate to long half-life parent compound.
Let me ask you about the post-mortem redistribution. Was that well, let me ask you first, do you know where Michelle MacNeill's blood sample came from?
I believe it was taken out of the heart.
And do you know when it was taken?
It was taken approximately 24, 25 hours after her death.
Okay. How does that affect your analysis, those two factors?
The important piece is from my perspective, is that you have a possibility that if postmortem distribution is occurring, that these levels that were seen on the tox screen may actually be higher than what they were at the time of death, or what we call ante-mortem blood levels that would have been present.
Ante-mortem meaning before death?
Before death. The next step that I factor there is to look at the length of time. The 24 hours is not an inordinately long period from the time of death until the time an autopsy is conducted and the sample was collected.
So the fact that it's not an inordinately long period of time, does that mean, well, what does that mean?
That means there's less likelihood of a major shift in the concentration of drug from tissue back to the blood. That doesn't always mean that that's the case, but it's generally until we can see some other factor such as the physical chemical characteristics of the drug or the volume of distribution of the drug, as we've already talked about, that would say, well, how much weight do I want to give to that? And the information in my mind is part about how much weight do I give it, but it's about the combination of the 5 drugs that's important.
Okay, I'd like to talk about the combination in just a minute. First, can you describe whether you factored in postmortem redistribution at all when it came to this analysis?
To a degree, yes.
Can you explain?
Well, you always keep that in the back of your head when you're looking at what those concentrations mean. And it was less of an issue if it had been a single drug. It would have been a larger factor in my mind than when you have a polydrug situation.
That's because the combination effect.
The combination of drugs.
You remember testifying in this case before a preliminary hearing last year?
Yes.
Do you remember defense counsel asking you to calculate postmortem redistribution for these 4 drugs?
Yes.
And at that preliminary hearing, what were the ratios that you used in those calculations?
I don't recall the specific numbers, but they were quite high.
Okay. Is it fair to say that that defense counsel supplied you with the numbers that you used?
Objection, Your Honor, misstating the evidence.
How so?
He provided the numbers. That's set forth in the preliminary hearing transcript.
You may cross on that.
Okay, let me did you calculate postmortem redistribution on this toxicology report at that time?
I'm sorry, for the record, my recollection of the preliminary hearing transcript is that you provided some and he provided some.
That's my recollection as well.
I think he provided the numbers. I used the calculations based upon the high end of the range of the numbers that he provided.
Okay.
Fair enough. That's a subject for cross. Go ahead.
And with that clarification, the high end of the numbers on the range for postmortem redistribution, did you use those high end numbers to make your calculations?
On my initial assessment, no.
Okay. When you did it with defense counsel last year, did you use those high end numbers?
Yes.
Did you come to a conclusion at using that high end of the range of postmortem redistribution, assuming the highest numbers in that range that you supplied, did that affect your opinion that you had rendered earlier?
No.
Why is that?
Well, twofold. One is...
Objection, Your Honor. Foundation, may this be a time like in voir dire in relation to testimony about postmortem redistribution?
Can you state your question one more time?
You're
You're asking whether or not the calculation of postmortem redistribution at high-end ratios affected his opinion.
That's correct.
He said no, and you were about to say why.
Why not?
Yes, you may voir dire. Go ahead.
Maybe as a housekeeping matter, we've moved to admit Defense Exhibit B that's been discussed. And
Any objection to the exhibit? Defense Exhibit B is received. Could I take that from you, please?
Dr. Dawson, at the preliminary hearing, we had a fairly lengthy discussion about postmortem redistribution, correct?
Yes.
And we discussed some professional literature in the forensic science community.
I believe so, yes.
And we discussed an article from the British Journal of Clinical Pharmacology, correct?
Yes.
And you indicated that that's a reputable journal in your profession?
Generally, yes.
In fact, it's a top-tier journal, you indicated.
Probably, yes.
And we discussed a number of other journals as well, right?
I recall we did, yes.
And you indicated to me that postmortem redistribution is a hotly contested issue in the forensic science community.
Generally, yes.
And I asked you if you could provide any articles that would support the extrapolations that you were making from post-mortem heart samples to ante-mortem conditions. Do you remember that?
I believe we did discuss that, yes.
And you weren't able to provide any citations then, correct?
Yes.
Do you have any now, any citations to any professional literature that supports the methodology that you're using to evaluate post-mortem heart blood and make ante-mortem conclusions? There's
been a number of discussions that have gone on in the forensic toxicology literature about that in the last year.
Can you give me one citation?
I don't have it at the tip of my tongue now.
You knew I'd asked you about that before, right?
I don't recall the specifics of our discussion.
Okay. May I approach on it?
You may.
Showing you the same article we discussed last year from the British Journal of Pharmacology. And have you reviewed this article since the preliminary hearing?
Yes.
And this article goes through a number of the things that you've talked about today in relation to postmortem redistribution and factors to consider, right?
Yes.
Talks about the lipophilic characteristics of some drugs. Talks about metabolism. Talks about solubility. Talks about movement of the drugs from tissue to blood, right?
Yes.
If you turn to page 435, and the first column and the third paragraph down, the paragraph starts redistribution from the lungs. You see that paragraph?
Yes.
And in the middle of that, this article indicates that movement of drug from the lungs into the left ventricle and aorta after death is rapid and results in a significant increase in drug concentrations in samples from these two sites. Isn't that correct?
Using the examples, there were 3 drugs that they were talking about.
Here, they're just making a general statement, right, about redistribution from the lungs.
Should we read the whole paragraph?
Sure.
Redistribution from the lungs, which act as a reservoir for basic drugs that are also lipophilic, such as amitriptyline, chlorpromazine, and methadone, is also important. Movement of drug from the lungs into the left ventricle and aorta after death is rapid and results in significant increase in drug concentration in samples from these 2 sites. They were talking about the examples that were used were the 3 drugs, amitriptyline, chlorpromazine, and methadone.
Well, it just gave those as some examples. It didn't limit the discussion to those 3, did it?
That's the example they used to illustrate their point.
You turn over to page 436. Again, in the first column. And the third paragraph down starts for all these reasons. It says, for all these reasons, the physiochemical properties of drugs which determine their distribution will not remain constant after death, and calculations based on pharmacokinetic parameters determined in life are bound to be inaccurate. the practice at one time common in forensic work of calculating the body burden of a drug from the postmortem concentration and the average volume of distribution determined in vivo should therefore be abandoned. Correct?
That's their opinion, yes.
And are you aware of any article or any professional publication that disputes that currently?
I'm not aware that we were calculating the body burden. I'm not sure what they mean by that.
I'll turn over to page 437. At the end of the first column, referring to the last sentence there, it's talking about the C to P ratio. C referring to central or heart.
Cardiac.
Cardiac. And P, peripheral or femoral vein, right?
Refers to peripheral, yes.
Right. Typically, as you indicated, preferred site would be femoral to obtain a peripheral blood sample, correct?
Yes.
And so in relation to volume distribution, it says the C to P ratio exceeds the volume of distribution in 1 kilogram to the -1 degree for 15 of 33 drugs for which data were available. So the volume of distribution is not an indication of the upper limit for divergence between antemortem and postmortem samples. Correct?
That's what they state.
So volume of distribution is yet again another uncertainty, correct?
It's one of the factors that they did not find sufficient data in their 15 of 33 drugs for which they looked at. But you also have to understand one very important thing about this paper. This is not original research. This is a meta-analysis of data for almost 30 years, over 30 years, 34 years.
It's a compilation of lots of research, right?
No, anecdotal reports, not research, anecdotal reports.
And this is in a peer-reviewed journal, right?
Yeah.
That you indicated was
Yes.
top tier.
Yes.
And then the conclusion on page 440 says there is no reliable or obvious connection between concentrations measured in life and subsequent to death. Consequently, concentrations measured after death cannot generally be interpreted to yield concentrations present before death. Correct?
That's what they say.
That's true, correct?
That depends.
For drugs that are subject to postmortem redistribution, that's a correct statement, right?
That depends.
Oxycodone, promethazine, diazepam, zolpidem, those are all drugs that are subject to postmortem redistribution, correct?
That depends.
As you've testified here in court today, you've indicated that you're unable to say exactly what the circumstances were before Michelle passed away based upon the postmortem toxicology, correct?
Generally, yes.
And you've testified that in the mid-2000s, there was a shift in the forensic science community from preferring, maybe not preferring, but from taking blood from the heart to preferring to take blood from a peripheral source, correct?
Yes.
And that was because of the unreliability of postmortem redistribution from heart blood samples, right?
Generally, yes.
The heart, being in the central part of the body, is subject to redistribution both from the heart muscle itself into the bloodstream, but also from the lungs and other tissue around the heart, correct?
Yes.
And we talk about central to peripheral ratios. those are based upon studies done primarily from blood taken during autopsies, correct?
They're, again, anecdotal reports. It wasn't a scientific study, but yes.
You haven't seen any scientific studies regarding creating central to peripheral ratios from autopsy blood?
There is some recent work that was looked specific at simultaneous obtaining samples from cardiac and femoral vein and analyzing the two of them and comparing them.
I believe that's all the foundational questions I
Thank you.
have. May I present argument now, or do you?
You raising your objection? Are you raising your objection again, having heard the
Yes.
testimony? Okay. For the reasons previously stated, previously found by this court, the objection is overruled. You may continue.
Okay. Mr. Spencer just provided you with an article called Postmortem Clinical Pharmacology.
Yes.
Is that correct? Did he provide you the whole article?
Say again?
Did he provide the whole article?
Apparently, yes.
Okay. Were you able to look at the abstract?
The abstract or references?
The abstract.
Abstract, yes.
What was the purpose of this study? What were they trying to figure out?
What they're trying to, they were looking at the
Foundation, is it referring to the abstract of the article or the whole article?
This is the abstract. That's what I understood the question to be. You opened the door. He may comment on the article. Go ahead.
They were trying to address the issue of the lack of adequate studies of the true relationship between fatal events and the concentrations that can be measured subsequently. And without such studies, clinical pharmacologists and others should be wary of interpreting postmortem measurements.
Okay. I'm going to have you turn to the conclusionary paragraph on page 440. Mr. Spencer read from the first part of that, saying we should be wary, or no, not we, but you should be wary about drawing conclusions from postmortem blood samples. Would you read the last sentence?
Postmortem concentrations have been overinterpreted in the past, and good evidence should be required before lethal concentrations are defined in the future.
Were you trying to determine lethal concentrations in this case?
No.
So this article, when it comes the cautionary tale, or the cautions that it brings forward, it's talking about calculating lethal concentrations.
Yes.
Would you look at reference number 8 of this article?
Yes.
What article does that refer to?
That's a article from 2003 out of the Journal of Clinical Toxicology and Clinical Toxicology regarding the postmortem toxicology, what the dead can and cannot tell us.
Okay. Who are the authors?
It was J. Lycan and W. Watson.
All right. If I may approach, Your Honor.
You may.
I'm going to have you look at page 50 here. And I'd like you to read that it's I'm sorry, I'm not sure how many paragraphs down that is. First sentence in the.
And it's the second full paragraph.
Thank you. Will you read? The second full paragraph, first sentence on page 50. What does that say?
An analysis of the drugs that have been shown to change in concentration after death can guide the toxicologist to the proper interpretation of postmortem drug levels.
What does that mean to you?
Well, it's a matter of putting it in the proper perspective. If you're looking at, is this a lethal dose, or is this simply a dose that would, or a concentration that would produce a pharmacological effect?
Is that saying that it can't be done at all?
No.
It's saying that it needs to be taken into account. Is that correct?
Yes.
Did you take that into account in this case?
Yes.
If I might approach again, Your Honor.
You may.
Could I have you turn to page 52, the second paragraph. Will you read that, please?
Thus, it is clear that the clinical toxicologist must address several issues to properly determine the role of a certain drug in causing death when presented with quantitative results.
Okay, let me have you parse that out a little bit. Quantitative results, what does that refer to?
The actual, what was quantitated or found in terms of concentration.
Okay, and we're talking about cause of death here, so the toxicology results, those quantitative results, come from dead people's blood. Is that correct?
Yes.
So what's the gist of that sentence?
Well, most importantly, they're talking about when you're trying to assign a cause of death, and when you're talking about levels that might be considered to be in and of themselves lethal.
Is that something we're talking about in this case?
Well, that wasn't, I was looking at the combination of the drugs, not the individual drugs.
Can you finish that paragraph?
These issues include, 1, were samples collected from multiple sites analyzed for determination of blood drug concentration? Question mark. Where were these samples collected from? Question mark. Item number 2, is the drug either known or suspected to undergo postmortem distribution? And then they reference a table.
Now, are some drugs not susceptible to postmortem redistribution?
Yes.
According to current literature?
Yes.
So when you said earlier, in response to Mr. Spencer's question about whether things, you were saying that depends. I think you repeated that a few times in response to his questions. One of the factors it depends on is whether the drug even redistributes after death. Is that correct?
Yes.
Okay. What are other factors that they list there?
Well, they're talking here in item number 3, is there adequate scientific data available to define the concentration toxicity relationship?
What's that talking about?
Dose and effect, or what we would refer to as in pharmacology, we talk about LD50, the lethal dose 50, or in other words, what is gives us some idea of how toxic a drug is. And
Lethal dose 50 refers to what number?
50% of the individuals given that dose will die.
Okay. Do you do those studies on people?
No, we do them in animals. Yeah. Our patients tend to get cranky when we do that.
Sure. No, it's kind of obvious we don't do those types of studies on people. But the fact that we don't do those types of studies on people, does that leave us with a lack of data?
No.
How so?
Well, we use the animal models tell us a lot about the lethality of a particular drug, whether it be from a cell toxicity standpoint, or just if you give a certain amount of a drug, they go to sleep and they don't wake up. And we look at what we call log curves, and where you do dose concentrations versus effect, and we want to be right in the middle of that in terms of the dose we give, because we know there's a dose and effect. We want drugs with what we call a wide therapeutic window. In other words, we can give a lot of different doses and not have problems with people dying. Drugs with very narrow therapeutic windows, you got to be really, really, really careful how you give them, because just a little bit of an overdose, they're dead.
Okay. That article, what's it published? What's the publication?
This was in where was it? I think it was Journal of Toxicology and Clinical Toxicology.
Is that a well-regarded publication?
Yes.
Is there anything in there that says the type of analysis that you've done here anything in that article or this postmortem clinical pharmacology that Mr. Spencer gave you that says it just can't be done, period?
Well, no, there's a very important point here, and what you're asking is very important when you start to compare these two papers.
Sustained, it's yes or no question.
Let me rephrase my question then.
Are you withdrawing the question?
I will withdraw.
Very good, rephrase. Or move on, whatever you'd like to do.
I'd actually prefer to move on at this point, Your Honor. I'd like to go back to the analysis that you were performing on Michelle MacNeill's toxicology report. I believe we were talking about postmortem redistribution, and I asked you the question whether calculating these numbers that you got on the toxicology report, running them through a postmortem redistribution calculation at the highest end of the range that was provided at the preliminary hearing, whether that would have an effect on your opinion. And so I'll put the question to you again, did it?
You lost me there.
Okay, I'm sorry. Is it correct to say that when you initially rendered your opinion on Michelle MacNeill's toxicology report, did you do specific calculations at C to P ratios for postmortem redistribution?
Initially, no.
Okay. When you were asked to do that at the preliminary hearing, I'm sorry, initially no, you rendered an opinion, is that correct?
Yes.
When you were asked to do that at the preliminary hearing, and you ran through those numbers at the high end of the range, did that affect the opinion you had previously rendered?
No.
Why not?
Because the numbers that were being used out of the postmortem clinical pharmacology paper, and that were subsequently, it was referenced as coming from the second paper, are based upon unpublished data and anecdotal reports.
When you talk about scientific study versus anecdotal report, what is the difference there?
Well, scientific study, you come up with you want to prove something. You come up with a hypothesis you want to prove, and so you design a study, a scientific endeavor to try to prove or disprove that hypothesis. And then you conduct the work, and then you analyze the data, and does it support your hypothesis? Anecdotal reports are, the scientific study is well controlled. You have controls over the patients you select. You have control over the animals you use, if that's the case. But in anecdotal reports, you are dealing with what we refer to as the wild types. And in animal studies, you refer to as wild types are the natural. I mean, it's whatever you find when you work with animals as opposed to a highly inbred genetic strain. And so when you deal with wild types, you take all comers. So you might have 10 patients in a row that you do the analysis on. Some of those patients were dead a day. Some of those patients were dead a week. Some of those patients were resuscitated or attempted resuscitation. Some of them weren't. Some of them were in water. Some of them weren't. You cannot standardize for that kind of analysis. And when you take a hard look at where that table comes from, those numbers become less and less reliable, particularly when they're looking at you look at the specific citations that they use for that table. They are anecdotal reports. They're case studies. They might have done 20 autopsies and looked at these things, but they can't control for all the variables in the individual itself.
So they can't control for all the variables that would affect the result.
Yes.
Scientific study can. You set it up in a very controlled environment, and so you narrow the variable down to the one that's in question to see what happens. Is that correct?
That's the goal.
So let me make sure I understand you correctly. Are you saying that you completely disregarded postmortem redistribution because the science is rough right now?
No.
How would you explain that?
The I was not attempting, and my goal was to look at when I see the combination of the drugs and their additive effects. I did not see a concentration there, even totally ignoring postmortem redistribution if it did occur. I didn't see a concentration there that would in and of itself, quote, be lethal.
Okay. So it's not like she died of an overdose of oxycodone?
Correct.
That you would try to figure out, was this amount reported in the toxicology report, does that reflect a lethal dose? Is that correct to say you were not working on that?
I wasn't working from that hypothesis because I realized the limitations.
Okay. So your conclusion, what was it based on?
It was based on the aggregate of the combination of the drugs and my training and experience in seeing people who are on these combinations of drugs.
Okay. How would an adult's body respond to those five drugs?
It would depend upon the concentration that's present in the blood, but if they are anywhere near the pharmacological doses.
Let me specify my question then. Well, let me ask you. You said none of those drugs represents, in your mind, what would be characterized as a lethal dose.
Individually, no.
Individually. Is any of them too high or too low?
No.
Are they within what you might describe as the therapeutic range?
In the loosest definition of therapeutic range.
Okay, will you define that for us?
Therapeutic range is probably one of the most misunderstood, misquoted concepts in pharmacology. A therapeutic range for you would not be a therapeutic range for me. What you look at is, what is the pharmacological effect? Can I give 5 milligrams of this drug to you and you get the effect that you need? That's therapeutic. 5 milligrams of that drug for me may not be. And so there's very few drugs we look specifically at, quote, therapeutic ranges. Anticonvulsants are one. Cardiac glycosides is another one. There's certain other drugs that we look at and say, this is the range I want to treat this person to, because I know if I go over that, it's going to be toxic. If I'm under that, I'm more likely not going to get the effect that I need.
Are you able to calculate the therapeutic range for somebody who's dead?
No.
So these drugs individually are not at lethal doses?
Individually, no.
Are you able to say whether they were within therapeutic ranges?
The drugs that, even taking into account even the wildest postmortem redistribution, there would still be a therapeutic effect in a drug-naive patient, and particularly in the combination.
What would the effect of that combination be?
Your Honor, may I have a standing objection to these questions so I don't need to interrupt?
You may.
These are all CNS depressant medications. When you add them together, you get CNS depression. And they can range from mild cognitive impairment all the way up to unconsciousness.
Okay. Hypothetically, if the doses, if the concentrations that you have on that toxicology represented concentrations in a living person, what would that effect be?
Objection, Your Honor, asked and answered.
Overruled, he may answer.
Those concentrations on their surface, it would be likely that that individual would be severely obtunded and unable to respond constructively to their environment.
Will you define obtunded?
Difficult to arouse, even asleep, not understanding or able to understand the circumstances that are surrounding them at that time, misinterpreting those circumstances, the cognitive impairment, it would be profound.
How about motor skills?
Motor skills would be affected.
And you said they could even be asleep?
Yes.
Would a person under that condition, would they be alert and aware of their surroundings?
They would not be alert.
And their awareness would be impaired?
Possibly, yes.
How would that have affected someone's ability to defend themselves against threats?
Objection, Your Honor, speculation.
Sustained.
That's fine, I'll withdraw that. I'll tender the witness at this point, Your Honor. sorry, can I have 1 minute?
Yeah.
I'm sorry, Your Honor, there's one thing I neglected to do, if I could have a couple more minutes.
Go ahead.
Your understanding of postmortem redistribution when it comes to diazepam. Is there demonstrated postmortem redistribution for that drug?
There's a range, and it depends upon the circumstances and based upon many of the things we already talked about. It can be from the low ones up to 3.
That range is derived from these anecdotal cases you've described,
Yes,
not from the scientific studies where every variable is controlled.
correct.
By doing it that way, how reliable is it to say this ratio that we have for the postmortem redistribution, we've narrowed it down to that variable and we can say that's a solid ratio?
Objection, Your Honor, foundation.
I'll withdraw it. It's a bad question anyway.
Sustained.
When it comes to oxycodone, what's your understanding of postmortem redistribution for that drug?
And again, there's a range. There's even some that were negative, but again, these are all the anecdotal reports, but it's generally in the low ones up to 2 or so.
A negative postmortem redistribution, what does that mean?
Probably something abnormal about either how the sample was taken or what was happening to that patient or whatever. I mean, this is the variability that gets factored into these. It gets turned into gospel. You have to be very careful about that piece of it.
If negative redistribution were actually happening, that would mean it would be going back into the tissue instead of the blood, right?
Exactly.
Is that something that seems likely to you?
No.
What about promethazine?
Promethazine is one that's very highly variable because of some inherent characteristics with the drug, but it has a very large volume of distribution, and it hasn't really been well studied or very well reported on. But it is noted to do postmortem redistribution probably higher than the others in some cases.
High volume of distribution for the drug, does that correlate to more likelihood from postmortem redistribution?
Yes.
How about zolpidem?
Zolpidem, its volume of distribution is quite low, but it's in the range of the others. But the postmortem redistribution with zolpidem is again in the low ones into the low 2s. Is the reporting range that's been reported. But there's very little information that suggests that to give us guidance about where did that 2 come from.
To come back around to your conclusion, those ratios didn't weigh heavily in your analysis because you're not trying to determine lethal dose, is that correct?
Correct.
The combined effect is what you opined about.
Yes.
And that was again?
Well, that an individual with that.
Sustained.
Okay, thank you.
You tender the witness?
I do, and can I retrieve the?
You may. Thank you.
I have one up there too, I left.
Yeah. In fact, could I collect all of those? Just make sure they get back to the clerk, the ones that have been offered. Ladies and gentlemen, we'll take our afternoon lunch hour. Let's reconvene here at let's see, 1:30. Let's go to 1:30. Please keep in mind my admonition to you. Don't form or express any opinion about the case. Don't discuss any subject of the trial amongst yourselves or with anyone else. Do no research on your own computer or otherwise, and avoid television, radio, or internet news coverage of the trial. Court's in recess. Yes, you may step down. Thank you.